Good afternoon and welcome to our webinar. My name is Daphne Styriadis and I'm Senior Associate with CAQH Core. It's my pleasure to welcome you all to part 2 of our prior authorization automation case study, and we're joined with Cleveland Clinic and PriorAuthNow. Today's agenda will start off with an overview of CAQH Core and a level set. We'll break down some of the barriers to prior authorizations and key findings from the CAQH index. And then we'll jump into the meat of the presentation. We'll review key findings and results from the case study. Then we will contextualize these findings in a larger discussion of improvements to the prior authorization workflow before we turn it over to our speakers for a panel discussion, followed by a Q&A. Some quick housekeeping items. You can access the presentation slides now in the handout section of the GoToWebinar menu on the right of your screen. You can also download the presentation slides and recording on our website after the webinar. A copy of the slides and the webinar recording will be emailed to all attendees and registrants in the next couple of business days. As a reminder, questions can be submitted at any time using the questions panel on the GoToWebinar dashboard. These questions can be any technical issues that you're having, as well as questions for our speakers, which we'll address during the Q&A portion at the very end. We're really excited to have Daniel Medved, Director of Revenue Cycle Management at the Cleveland Clinic, and Dan Beadle, Senior Vice President of Customer Operations from PriorAuthNow, joining us here today. From the CAQH side, we have Christine Bernaska, Director of Research and Measurement, Bob Bowman, Director of Core, and Mariana Singh, a Senior Associate at Core. With that, I will turn it over to Bob and Christine for the CAQH Core overview and level set.
Great, thanks, Daphne. If we move to the next slide, that'll be slide 6, if you're following along, we want to highlight what we've learned over the last couple of years working in this space for prior authorization as it relates to barriers. Many of you on the call all probably have experienced a variety of these barriers, if not all of them, if you work in this space. But highlighting these really helps us here at Core define many of the tenets of kind of what we do, right? Not only do we write operating rules, which you may know us most famously for, but we also work within the industry to identify these challenges, these barriers, and then work through ways to mitigate them, either through education, like the example of this webinar, through different initiatives, like what you're going to hear throughout the webinar, the actual case study that we've pulled together, as well as continuing the education components of working within the industry and the other movers and shakers and players to better mitigate these types of issues. As you can imagine, the burden that providers have, and we'll have Christine walk through the index findings in just a moment to really highlight the impact that the burden is, both on providers as well as health plans in conducting a prior authorization interaction. And I use interaction specifically in that way because that could identify a manual means, right? If a provider has to fax clinical documentation to support medical necessity, that is an interaction related to prior authorization. Say the word transaction to mean the actual HIPAA mandated 278 transaction that exists for the ease of conducting a prior authorization. We'll hear more about that too. But this lack of consistency is not just between systems and a standard or lack of a standard, but even within the data that is used by a provider to submit a prior authorization request. Every health plan may have a little bit different data set that they need to not only initiate, but also then to adjudicate that prior authorization. There's also a lack of integration, as you can imagine, between a provider's practice management system, their EHR, and then how do we combine that data together to put or submit an inquiry or a request for prior authorization to a health plan, who may also have divergent systems on their end that are not fully integrated, especially if these particular prior authorizations are a carve-out, or these services are a carve-out. As you can imagine, it becomes more and more complicated. There are limited availability for vendor products and services within the marketplace. And so we also have that kind of mitigating factor of how do we ensure that the vendors are there to support both the provider and health plan clients. There are state requirements that insert usually very manual steps in the process for prior authorization. So you have that particular problem as well. There is a lack of understanding. And by this, we mean many providers are unaware that there is a standard that's required under the HIPAA regulations to be used for prior authorization. Unfortunately, or fortunately, since there may be vendor problems, there's lack of integration, it might be really hard to use a 278 transaction. So many health plans have other tools and services that they provide to their provider community to support prior authorization. Many have provider portals, for example, right? Jump on our portal, key in the information, and we'll get that authorization initiated for you. And we can respond back to you probably in an email or back on the portal with that response, the prior authorization approval number, the number that's going to go into the claim when you submit the claim or the bill later, right? All of those kind of processes exist, but they're often very manual, which leads to that level of maturity. Prior authorization is usually just not that mature of a process. That interaction that takes place is still heavily reliant on 1980s fax technology or fax servers, right? Wait, we moved into the 1990s with the fax server. So that type of interaction is still taking place quite heavily in the medical industry. And last but not least, there is no federal mandate for an attachment standard. And again, those attachments that are often used for medical necessity are key to an adjudication for prior authorization. And without, oftentimes within our industry, if we don't have that stick or carrot of a federal mandate, it makes a fragmented environment. So different health plans do differently, providers have different options. And then how do you integrate those within a system to make it more possible to automate the entire process, soup to nuts, for prior authorization? So all of that kind of leads to lots of problems within healthcare when it comes to prior authorization. But there are several folks that have been working on this, and on these particular problems. We'll hear more about how some of these solutions have come to a maturity level that really supports provider health plan integration and automation. But before that, I'm going to hand the call over to Christine, who can walk us through some of our findings from the index. Christine?
Great, thanks, Bob. I'm on slide 7 right now. And Bob, that was a great transition to this slide that presents data from the 2020 CAQH index, which highlights opportunity areas related to prior authorization. So for those of you not aware of the CAQH index, it is an annual survey of medical and dental plans and providers that tracks the adoption of electronic administrative transactions, as well as the cost and time savings opportunities associated with moving from manual and portal transactions to fully electronic transactions. And among the administrative transactions tracked by the index, prior auth remains the most costly and time-consuming transaction to conduct and has the lowest rate of electronic adoptions for many of the reasons that Bob just discussed. Now, before I get into the data that's shared on this slide, I want to let you know that for the index, prior authorization refers to a request from a provider to a plan to obtain authorization, or a response from a plan for an authorization. It does not include follow-up or referrals. And this is something to keep in mind as I'm sharing the index data here, given that I know there's other studies out there and they study various components of the entire prior auth workflow. So if we look just at the cost to conduct a prior authorization, we see that it costs the medical industry, which includes health plans and providers, $13.40 per transaction to conduct a prior authorization manually, which is by phone, fax, mail, or email. and then $7.19 to conduct a prior auth via a web portal. When you think about that and the data that we collected, by switching from manual and fully electronic transactions using the 278, the industry could save $9.64 per transaction for an estimated total savings opportunity of $417 million. Now, if we look at the administrative burden associated with time to conduct a prior auth, we found that providers spend on average 20 minutes conducting a prior authorization manually, either through the phone or fax or mail, compared to 8 minutes when using the HIPAA standard. So if you think about this, providers could save 12 minutes per prior auth if they conduct the prior auth using the 278 as opposed to conducting it manually. And when you think about the number of prior authorizations conducted in a month, that savings can add up. And we'll see when Dan goes into presentation, you'll see some of the volume numbers for prior authorization. And just it's interesting to keep in mind then these savings opportunities by switching over to an automated process. And if you go to the next slide, you'll see a bit more detail on the costs associated with conducting a prior auth using the 3 modes that we track, as well as the adoption rate. So when you look at the cost to conduct a prior authorization, we clearly see the difference in cost between the modes for plans and providers. So in that top upper table, you'll see the breakdown of those numbers. So you'll see that conducting a prior auth electronically using the 278 costs significantly less than conducting the prior auth manually or through a web portal. And this is important to consider as we're going through this presentation and just thinking overall about the industry and how they're interacting with prior auth and the initiatives taking place. When adoption of the 278 standard is low and prior auths are typically conducted either through a web portal or manually. And while the adoption of the electronic standard is steadily increasing, so you'll see over the last 3 years, there's been a slight uptick in the adoption rate. Those are the bars on the bottom. Still, we need to do more to foster and encourage the use of the electronic standard in workflows. And by doing so, this could help reduce the administrative burden so that the industry, particularly the plans and providers, can focus more on delivering patient care. And with that, I'm going to turn the presentation back over to Bob, who will introduce our efforts to help evaluate the impact and benefit of standards, operating rules, and technology on the prior auth workflow, so you can get a more holistic view of not only what we are doing here at CAQH, but how some of these important benefits related to the standards, rules, and technology are impacting the overall workflow. So Bob, back to you.
Great, thanks, Christine. And briefly, just as Christine mentioned, we do want to share with you that this is part of one of our initiatives here at CAQH, and that is to really conduct a pilot and measurement study for prior authorization. And as Daphne mentioned too, this is part 2. So hopefully you had a chance to review part 1 if you didn't attend it originally. But in part 1, there were specific components of that study that really helped shine a light on, again, some of the burden of conducting prior authorizations, but also to help find solutions to improving the workflow and some of the technical specifications around the transactions that are used, as well as some of the technology that can be used to help automate the process. So again, just as a reminder, back in 2020, we actually did a site visit to Cleveland Clinic. We worked with Prior Authorization Now. They gave us great insights into what their specific solution was and how it actually integrates with Cleveland Clinic. We also, in Cleveland Clinic, and Dan can speak more specifically about this, especially during our Q&A or during our panel discussion, this first part also included a provider satisfaction survey. So we went to the clinicians and asked specific questions. We went to Cleveland Clinic staff and asked specific questions about how the automated solution that was implemented helped improve the process, both again from the clinical side as well as from the staffing side to the situation around prior authorization. All those findings are part of that initial webinar that we did last year. This second part for today is specific around, again, some of the questions and interesting answers that we had from our first part, and that was to do a cross-sectional comparative analysis on a very specific use case, and that was diagnostic imaging. So we were able to do a deep dive into that specific service, which is often used again for diagnostics, which then leads to the next set of services that a patient may need. So we were able to look at the overall prior authorization environment at Cleveland Clinic. What is the first pass status, right? Wow, first pass for PA. Yes, it is possible. You'll hear more details around that in just a moment. Touchless authorizations, again, a fully automated component of PA processing. Are there instances where authorizations that required additional clinical information was needed? Yes, we'll talk about what those scenarios mean and how an automated solution directly impacts that, not only the request for the clinical information, but how the provider delivers the clinical information back to the health plan for that review. And also one that is always near and dear to many providers' hearts is when PAs kind of elevate, I'm going to say the word escalate, to a peer-to-peer review with an expert at the health plan, and you have to conduct that peer-to-peer review. Are there, in this particular use case, are there findings or savings or more efficiencies because of that integration and a more automated way of doing it? So again, all of that information a little bit later, but just again, as a quick recap of the intent of what we're trying to do, down on the next slide, on slide 10, is some of the findings and key findings from the survey, the staff satisfaction survey that was conducted last year. Again, this solution that, again, PriorAuthNow and Cleveland Clinic will go into a little more detail in just a moment. It really does rely on AP functionality, that technology for an automated real-time interaction between the provider and the health plan, with that software solution application in the middle, using the 278 transaction, using specific prior authorization operating rules, right? We have to identify the patient, we have to have specific response times, we have to be able to identify any issues and clearly report those back to the provider so they can make corrections or amend the data that comes in. They have to be able to identify the correct PIND and what that PIND means, and then be able to work that PIND to understand that status of the transaction, and then finally actually get to the final resolution of the prior authorization request. Is it denied? For what reason? Is it approved? Yay. When can we schedule a service if we haven't already? And then if there's additional work that has to be done, exactly what those error or PIN messages are, so that additional work can move forward. So as you can imagine, that work that we did in the first case study and now moving into the second one, you see there's a reduction in time to complete tasks. There's a reduction in the wait times between steps. So even between that workflow, as you can imagine, all the multiple steps that take place, any reduction along any 1, 2, or 3, 4 of those steps along the way really helps bring more timely care to the patient. Again, increase in automated real-time interaction. That real-time interaction with AP technology really is functionally equivalent to moving that needle really, really fast and making things better. And again, also increase in staff satisfaction. Working through an automated solution versus printing off cover sheets and going to the fax machine really helps expedite the process for prior authorization. With that, we'll move into the meat of our discussion, and I'll hand the call over to Dan.
Thanks, Bob. So good afternoon, everyone. I am Dan Medby, and I support the prior authorization process here at Cleveland Clinic, and excited to walk through some of our findings and takeaways from our second dive into this case study. And so as we go to the next slide, this will really just create some of that overview for what we're looking and discussing about. And I know it was mentioned earlier, but we really took a scope of services and the scope of work and really tried to target that. And so we really focused on a set time period for our work and what we're doing. And so when we launched with PriorAuthNow back in mid-February, we had a staged approach in terms of how we got there and how we started the integration. And quickly after we launched, we decided to start expanding and including as much services and as many payers that we could support through the process. And really the focus here is the diagnostic imaging. And with the study itself, we really focused on a set time period of comparing both services that are going through PriorAuthNow and that same subset of services that are not supported through PriorAuthNow. And so various payers that aren't using the solution, we really tried to measure those so we can get a clear understanding of what the impact is. In our first session, we discussed, what the staff impact was. So how do they feel, the comfort with it, the ease of using it. That was the first focus. Here, we're really going to dive into the metrics to really show and highlight what the solution can do and how it can transform access. As we move to the next slide here, these are the main measurements that we're focusing on. So we're looking at the touchless authorization, which are authorizations that actually get obtained without us interacting with the case. And these are not just no pre-cert required. This is, we were able to exclude that out. These are actually approvals that we obtained through the solution where we did not have to interact. It didn't require a survey. It didn't require our clinical submission. First pass status is the second measurement. And really, again, it's looking at how authorizations were obtained without having barriers or delays, peer-to-peer, the needs for additional information after we already interacted with the case once. That's a huge measurement because when you look at the timeline of a prior authorization, that is huge and key in terms of being successful. And then the next two items really are looking at the authorizations pending for additional clinical information. So when we need to interact with a case to send clinical, what is that in terms of timeline as well as understanding what volume that is pertaining to what our comparison is as a 100% manual process. And then looking at peer-to-peer, and while the solution necessarily does not have a direct impact on the rate of which a peer-to-peer occurs, because that's still dependent on the clinical appropriateness of the test and the right information being sent, we wanted to make sure that we weren't seeing any negative impacts from the solution. And then overall, so understanding what that timeline is in terms of the approvals that we're seeing. So those are the 5 measurements we're really going to focus on. And again, it's looking from June 2020 through February 2021 is our data set in terms of both the PAN supported work and the non-PAN supported work. So the first metric we're going to dive into really is what's automated. So the overall timing. And so when you look at the automation and no automation, the volume is based on that time period that I laid out and what actually was going through the automated process versus not going through an automated process. So our manual work as it is now. Overall, there was about a 6.7 day improvement when using the automation in terms of turnaround time. So in terms of our average turnaround time of 10.8 days when we're manually processing and going out to the portals, building the case, submitting it, and then constantly following up, and we may follow up every day, every other day, depending on how far out it is, that can extend that tail. With the solution, those and leveraging the 278 and the core operating rules, those notifications and that removal of waste and time, so evident and real. It's 6.7 days. That's huge in terms of providing access to care. Put yourself in a patient's shoes. The last thing that you want to do is wait. You're sick and there's a test that's needed or something's needed. Waiting it builds anxiety, and that can cause and have a negative impact on the patient's well-being, family's well-being. To be able to improve that through the automation solution is real. The second metrics we're going to look at here are the true automation and where this is driving success. And so we'll look at the first one, looking at the touchless authorization. And really, this is the amount of authorizations that were obtained, and these are actual true authorizations. We received an authorization number from the payer when the transaction occurred. We saw this at about 26% of the time. And so that 5,545 cases was out of the total authorization, the total automation number. And that's huge. That 26% of that work we did not have to interact with. Those were real time. So you see the average time for when that case was booked to when we had that decision was 0.29 days. And the way that we're set up at Cleveland Clinic with prior authorization now is if the service is scheduled less than 30 days, it's an automatic trigger out. And so that's where we have real opportunity, especially as you know, the industry standards, the goal in theory is to get to 30 days out. This makes that much more of a reality. With the touchless authorization, there isn't a measure for this when it's not automated, because we have to touch it. You have to get involved. You have to manage it. You have to go out and check it or manual mark it, no pre-cert required. When looking at the first pass, again, that's the approval that's obtained without a case resulting in the peer-to-peer or the additional interactions where we have to touch the case 2, 3, 4, 5 times. You know, we saw a consistent amount there, which is good. Again, that is dependent on the service being clinically appropriate. So the fact that that measurement was there on par with our non-automated work is validating. That's the right metric that we're looking at. The enhancement and improvement was the gain in days. So almost 8 days improvement from when a case is first pass approved compared to when it's first pass approved without automation. Again, that builds in those lag days of having to touch the case, go out, follow up, check on the status. It's pending, so you'll drop it to the next day, and then you constantly are going back and touching and interacting with it. So the opportunity here where we're able to secure those approvals in a much more timely fashion with limited touch and impact is real. And that's what we were able to identify here when we looked at these 2 different measurements. The next set of measurements are looking at the pended for additional clinical information and then the peer-to-peer. And again, these necessarily aren't a measurement that the solution would improve, because this is all dependent on the information being valid, that it's the right clinical pathway, that, you know, if you're getting an MRI of the hip, that they want to see the consult, the x-ray, conservative treatment, that still has to be there, especially for the peer-to-peer. For the clinical for the pending for additional clinical information, that reduction in terms of that volume shows is a component of the touchless authorizations. So 73% of the time, we have to interact with the case in adding additional information, answering the survey. If we're manually processing, obviously that's 100% of the time. So not only is that an administrative efficiency there, when we do have to send the clinical, we know those will take time to review because they need that human interaction on the payer side to review, assess, and determine there. It still was a great improvement of 4.3 days. And that allows, again, still to meet and exceed the clinical expectations in terms of time to treat. So I know at Cleveland Clinic, a lot of our providers, their time to treat is 7 days or less. You know, they have their metrics and they have their determinations around patient care and the impact that can cause by, you know, delaying that further. And so this continues to support that in a strong way. So it's supporting patient care, supporting access to care. When we look at the peer-to-peer, again, the percentages are right on par with where we expect to see it compared to our non-automated work. And the reason for that is that it's dependent on, was the right information sent, is the right information there to begin with. Those are what are driving the peer-to-peer. And this was important because we wanted to make sure that there was no impact with the automation that would potentially be causing some of the issues. And so that was on par with what the performance was with non-automated work. But we did see an improvement there again in that final adjudication, that being informed of that final decision after the peer-to-peer was at 8 days compared to almost 19 days. So an 11-day improvement there. So ultimately, when you look at these metrics and the measurements, the removal of the administrative burden is huge. It allows the caregiver to focus more on what matters most. And that's the clinical piece of the prior authorization process. The case creation, the determining which portal to go to, that's all necessary and valid. But does a human have to do that? No. Where can the human interact most? And so, as one of the earlier slides mentioned, the avenue to streamline and transform this work is there. And leveraging these standards are really the opportunity to trailblaze and to overhaul the pre-service experience for both the patient, the provider, everyone that's involved has the benefits from leveraging these solutions and leveraging the core operating rules and leveraging the standardizations. So that's really an overview of the performance in terms of the efficiency that's gained, the timing, the removal of waste in process. That is key, and that is the core driver through these solutions and through any real AI-driven solution is where can we remove waste and time? That's a core principle of continuous improvement. And this solution really has helped drive that. The study here has confirmed our experience from a individual standpoint and a system standpoint, what the impact is. It was really great to be able to show this performance and show these numbers in comparison in terms of what that impact can be, again, to patient care and to the patient experience and the provider experience. So thank you for your time. We'll turn it over to Mariana, who's going to take it on from here.
Thanks, Dan, for that great overview of the case study and impact of automation from a patient scheduling to prior authorization adjudication perspective. On the following slides, I'm going to speak to the impact of automation when conducting a single prior authorization and how technology standards and CAQH core operating rules work together to bring automation. Before there was an automated process, every step to conduct a prior authorization was done manually. From the staff creating a case after an appointment was scheduled, to accessing a payer portal, to submitting a prior authorization request, then waiting to hear back if additional clinical information was needed. And if so, submitting the appropriate information, then having to manually follow up for a final determination status and updating the Epic system with the appropriate status. Every step was done manually, and on average, this process would take 45 minutes to complete a single prior authorization. On this next slide, we'll see on this next slide, we'll see that the prior authorization now solution was able to leverage API technology, the X12278 standard, and CAQH core operating rules to bring automation to Cleveland Clinic staff's prior authorization workflow. If we look at the example of an MRI being scheduled, the API technology auto-generates a case for a prior authorization request to be submitted after a patient has scheduled an appointment for an MRI. After the case is created with pre-filled information, a prior authorization request is auto-generated and submitted to the health plan in real time. In that same moment, a real-time response was returned from the provider indicating a need for a clinical survey. The clinical survey captures specific data related to the prior authorization request and is often customized for that specific type of prior authorization, as mentioned in this case, diagnostic imaging. The longest time to conduct this automated prior authorization request is the time it takes for Cleveland Clinic staff to begin working on the prior authorization after it enters their work queue. From their EHR, Cleveland Clinic staff is able to answer the corresponding request for additional information and submit the appropriate information without ever leaving their EHR. Within 4 minutes from submitting the additional information, Cleveland Clinic staff receive a response to final determination, which is automatically updated in their Epic system. A process that used to take on average 45 minutes, as we can see, is reduced to 4 minutes. Technology standards and operating rules work together to automate this process at different steps of the workflow. The API technology is integrated into the EHR and pulls the correct information. The standards create a consistent set of data to send the request for a prior authorization, and the CAQH core operating rules provide the requirements, sending the requested data in a timely manner. On this next slide, we can see the use of technology standards and CAQH core operating rules enable the real-time exchange of robust data to accelerate prior authorization adjudication and ultimately enable timelier delivery of patient care. As Dan mentioned, from the time a patient appointment is scheduled to a prior authorization being adjudicated, the overall timeframe was reduced by 6.7 days when using the automated process, allowing patient services to be scheduled and conducted more quickly. This greatly reduces the need to reschedule a service because the prior authorization has not yet been authorized or approved. Providers can be confident with scheduling the services, and patients' anxieties can be put at ease. A metric related to the CAQH core operating rules included authorizations that were pended for additional clinical information. These were adjudicated on average 4.3 days faster because of the automation. This was due to the fact that providers were submitting more accurate data and information to the health plan initially, and thus health plans were able to ask for more specific information to adjudicate the request. Cleveland Clinic staff knew exactly what data to include at the beginning of the process, so less authorizations were pended for additional information, and for those that were pended, were able to provide the specific data needed for the prior authorization to be adjudicated. Even the most cumbersome of prior authorization processes, authorizations that require peer-to-peer review, were adjudicated 11 days faster when submitted through the automated process versus those that could not be, which is a substantial impact to the delivery of care of these often needed and very extreme services. Through automation, we see diagnostic imaging, and many of the subsequent services are expedited in their delivery. The time to evaluate and diagnose a patient are substantively and greatly reduced, allowing for more timely care. So as we can see, the standards, technology, and core operating rules really make a difference in automation. On this next slide, we can see that following this webinar, CAQH Core, Cleveland Clinic, and PriorAuthNow are collaborating on an issue brief to be published in November that will detail the findings we've heard today. So be on the lookout for socials announcing that publication. The CAQH Core Prior Authorization and Pilot and Measurement Initiative will continue, and organizations are collaborating to share their stories on building more efficient workflows and processes through automation from the use of technology, standards, and operating rules. We invite other organizations to join and get involved. Christine and Bob will speak more to this during the panel discussion. Additionally, if your organization has any questions on implementing the 278 standard, CAQH core operating rules, or core certification, please feel free to reach out to us at core@caqh.org with any questions. Lastly, the 2021 CAQH Index will be published in early 2022 with findings on other transactions and cost savings opportunity for industry. If your organization wants to participate in the 2022 CAQH Index, please reach out to Christine with any questions. I'll now pause here for a quick polling question before turning over to our panel discussion.
Thanks, Mariana. So I'm going to go ahead and launch this poll to gauge audience interest in participating in any future pilot measurement initiatives. So just a quick yes, no, would like to learn more about it, and someone from our team will reach out to you with more information. All right, I'm going to go ahead and close the poll now and turn it back over to Mariana for our panel discussion.
Thanks, Daphne. Now we're going to answer some questions specific to this case study. Our first question is actually for Dan Medvay. How did the implementation of a prior authorization automated solution impact administrative burden. We know in part one you spoke to the staff satisfaction increase that occurred. Now that you've done a deeper dive, what has this meant for Cleveland Clinic as a whole and as a result of patient care?
A great question. I think the first thing is staff engagement and staff empowerment. From the get-go, our team saw this as a real opportunity to improve, and we were very transparent in terms of what we were looking to do and what the solution was expecting to do. And so that was critical to the success, not just from a metric standpoint, but from getting it up off the ground. It was a big opportunity. And so the team that was really engaged, really was awesome to see. And our rep level individuals can speak to the impact. They can speak to the process. It's great to see that because that just shows how invested they are in this. And we have some individuals on our team that are known as the pan queens and kings because they're so into it. And so they've taken such a focused approach on how to leverage this. Where do we have opportunities? We've leveraged their ideas and insights through our continuous improvement process of how do we do this better? How do we get involved differently? What more can we do? And I think, that was great to see. The impact, the measurables, I mean, those are they speak for themselves. I mean, the removal of time, cutting things down from 11 days to 2 days or, 11 days to 6 days even, that's a huge gain and a huge transformation opportunity for that patient experience and everyone involved on that pre-service experience. Think about, how frustrating it is waiting. You go anywhere and wait. You wait at a restaurant, you wait in line to get a drink, you wait in an amusement park. Those can all be a negative experience. But the ability to speed that up and enhance that, along with other opportunities that we're pursuing to improve that patient experience, how do they have better visibility into their service requests? This is a tool that can deliver that to that patient, to the consumer much quicker. And so that's really what, the big takeaway from me on the burden and what was lifted. It allows us to interact differently and in a more efficient manner.
Thanks, Dan. Our next couple questions are for Dan Beatles from PriorAuthNow. Are only certain types of prior authorization requests able to be handled through the solution, or all of them? And can you also speak to how the solution works with elective surgeries?
Yeah, we support all. Our platform was built to support multiple service lines of prior authorizations, as well as the payers which support those procedures. And regarding elective surgeries, we can drive the same efficiencies you've seen here for diagnostics. When an authorization is required, we will work to understand the workflow, the nuances that drive and create friction, and then deploy our technology to drive automated processes.
Thanks, Dan. And another question we had was, we heard a lot today about how API technology was leveraged with the PriorAuthNow solution, and taking it a step further, thinking about the role of artificial intelligence, is PriorAuthNow planning to leverage that technology as well?
Yeah, artificial intelligence, or AI, seems to be one of the most used and talked about terms in healthcare right now. And while it plays a role in our approach to automated authorizations, it's just a piece of what makes our solution successful. And what I mean by that is what really differentiates us is how and where we apply it. Because we have direct connections with our payer partners, we apply our AI in a way that is coordinated with the payer, which significantly increases our automation rates. We don't have to fight the same challenges others do when trying to apply AI to an interface that payers have not agreed to support. These direct connections allow the transmission of structured first-party data directly from the EHR and flows seamlessly between our providers and payers, which ultimately leads to higher automation rates and greater efficiencies for both parties. Our solution provides value to payers, providers, and patients, which we believe to be the only way to right-size prior authorizations and really solve it for all stakeholders.
Great to hear. Thank you for that perspective, Dan. Our next question is actually for everyone here on the panel. There have been many efforts to study the effects of real-time implementation of a solution that reduces the burden of prior authorization. What do you think made this impact study successful, and what were some of the barriers? Dan Medvey, I'll pass it to you first.
So I think commitment was one. It took time, and we all have busy schedules, and babies happen and things pop up left and right. And so we remained committed to that for the most part. There were sometimes we had a shift last second, and mainly that was my fault. But it allows us to be committed to each other and to this effort. We didn't know what the end result was going to be, but we partnered together to really leverage data. And I think that's what really drove this to a success is we, leveraged data, we worked at the data, we looked at it, tried to break it down until we got to a strong place. And, it was nice to be able to validate our data set against Pan's data set and come up with the same outcome, which was really great. And then the outside the box thinking, I think was great. We're sometimes so set in our ways that we have blinders on, but we thought differently as we approached this and, looked at it bigger than just Cleveland Clinic or PriorAuthNow or CAQH. We looked at it from an industry perspective. And I think that allowed us to really drive ultimately what we were able to identify here.
Yeah, I completely agree. Dan Beadle, we'd like to hear you from a vendor perspective.
Yeah, again, Dan said it very well there, and not a whole lot I can add. But there has just been an incredible collaboration between the Cleveland Clinic stakeholders and the PriorAuthNow execution teams. And just like we do with every integration, we take extreme efforts to understand the intricacies of the manual workflows to ensure we are deploying our technology in an appropriate manner, ensuring we can deliver on the R value and strong return on investment.
And lastly, Bob and Christine, from a CAQH core and CAQH explorations perspective, what did you find to make this project so successful, and what were some barriers?
Yeah, maybe to build off of what both Dan said, understanding those intricacies of the workflow for very specific use cases really helps drive that understanding. Once you know from soup to nuts exactly what every step along the pathway is, it allows you to really kind of mitigate those hangups. When something gets stuck or pended, or there's a manual, the process drops to a manual component, it allows you to think about, okay, how can we actually automate this? What causes this problem? Is it a message back to the provider, or is it a message back to the health plan? What is it? And does something exist today that can help mitigate that? Is it a standard like the 278 that has a AAA error code that responds back and lets the provider know that this is wrong? Therefore, they can correct it and resubmit, right, and move it down the next step in that process. In core, we do the same thing, right? We work with folks just like Pan and just like Cleveland Clinic every day to understand those nuances and those idiosyncrasies of the process, because there are ways to make it easier. We just have to work together through consensus, right, and find the best way for everybody. Because it's great. I'm sure Pan and Cleveland Clinic is a great example of working together, and that solution works probably well with many other clients that Pan may have. It might not work for all of them in every situation, but if we can get, as we saw through our case study today, 80–90% of these move through much faster, less manual touch, it really increases that. We always go for 80–20 approach, right? If we hit that 80–20, if we hit anywhere near that 80%, it's a huge significant savings for everybody in the path.
And another question for you and Christine was, what does the expansion of the pilot initiative look like, and what does CAQH core hope to accomplish?
Well, I'll jump in first, Christine.
Okay.
I think that one thing that we talked about today is that the survey comes up perhaps on screen that a user has to interface with. And oftentimes that survey may include that additional clinical documentation. It might not just be a couple of data fields, it might actually be an image, right? That diagnostic image has to be reviewed by the health plan for that determining medical necessity. And so how do you get that attachment from the provider to the health plan? So our next step would be looking at, and we've been doing this over the last year, for attachment operating rules. What do operating rules look like for prior authorization attachments, for claims attachments too, right? That's also part of the scope. So looking at those examples where Cleveland Clinic and Pan exchange that type of clinical attachment information, as well as any others that are interested in joining with us in this initiative. So that would be our next component, is to look specifically at attachments and where the operating roles can help accommodate and simplify solutions.
Yeah, and then Marian, I'll just jump in. From a data and measurement perspective, I think what would be great, what I hope for is, to expand the sample. So I know we talked about getting other organizations involved in partnerships, and not only getting additional partnerships, but also looking at different lines of businesses or different services. I know this focused on imaging and diagnostic. I'd love to open that up more. Also think about expanding some of the content, some of the questions we asked. So I think we have a set of really solid metrics that we work closely with Dan on to make sure that the data was available and that we could have consistent data when comparing apples to apples. So I think looking at that, and are there other metrics that we can expand or increase the number of staff surveys we do, just provide more context. And then ultimately, what I'd love to do is start tracking this data, right? And by tracking it, we could then start looking at best practices as well as opportunity areas. And then perhaps share that with the industry and see then how we can potentially move the automated process forward.
That's a great perspective. Thank you for that, Christine. Our last set of questions is for everyone again on the panel. With these new perspectives you gained from this study, in your opinion, what's the next step to make prior authorization a smoother and less abrasive process for providers? And what is your organization doing next? Dan Medvey, I'll pass it to you first.
Thank you. Really, I think it's expanding, more service lines, more payers, and really partnering together, because the prior auth process, it's a two-way street, right? The payers have to be there, and they're a key part of this. It doesn't work if we don't have a payer commitment here, and really leveraging that to show this and being able to measure that performance. I think it's going to be huge, because that's how you know if this is working. You can see the impact, you can feel it, but when you actually get the data, you can tell that story. And being able to support patient access and access to care is critical. And looking at how do we leverage this to reduce the administrative burden, opportunities to gold card services, opportunities to enhance the clinical attachment aspect of it that was mentioned earlier. There's room there to grow and different avenues to take us down. And then I think the last part for me is, focusing on automating the easy and interacting with the challenging aspects. That's where we need a human mindset to do. And then that gives you an opportunity to empower your staff, to really engage them to drive and improve process. And when you have a staff that's empowered, you're going to see the results. And as our staff has become more comfortable with this and has empowered themselves more with this process and the solution, we've seen continual improvements outside of just this metric time frame. So we are continuing to look at this now monthly as we move forward, and we see the improvements in some of the key metrics. And that's just great to see, because that's the team that's driving that. It's not me. I have nothing to do with that. That's individuals that are in the work day to day, that are engaged and committed to this in their role. And so that's what I'm really looking forward to, and seeing this expand, seeing more payers get involved and really partner together to drive and improve process.
Yeah,
Thanks, Dan.
and just oh, sorry, Mariana.
No, go for it. You were next.
So I was just going to say, we are really proud. We are incredibly proud of the relationship we have with Cleveland Clinic and the efficiencies we've been able to deliver to their organization. As we said earlier, we built a platform that supports providers of all sizes and various types of workflows. And in line with our mission to accelerate access to appropriate patient care, the way we build upon that success is to continue attacking where the manual components that still exist within the workflow. And we're in the process of deploying technology now that allows us to automate the extraction and structuring of clinical data and map that information to the payer medical necessity requirements directly from the EMR. And ultimately, our goal is to turn prior authorizations into a point of care conversation between the patient and between the physician.
Thanks, Dan. We actually received a few comments in the question and answer portion. One question was related, is the system limited by the payer's readiness, or does it adapt to the various needs of the payer?
Yeah, so I'll jump in just from our perspective. Our goal there is to meet whether it's the payer or the providers where they're at today. So we're not limited by a single integration type. And so, yes, payers are a critical component of this, but our goal is to meet them at the technology level that they're at today.
And how does PriorAuthNow determine if an authorization is needed for a particular service and payer? Does this require provider configuration effort? What happens when the payer policy changes?
Yeah, again, because of the coordinated efforts we have with our payers and the connectivity we have with them, they are the one making that determination, not us. So we're not, building things on our side. We are, again, that first party data flowing from the EMR is being passed directly to them, and they're ultimately making that decision. So when the policy changes, that direct integration knows about it right away because it is directly connected with them.
And go for it.
I'm sorry, I can add on to that. So from a provider side, we have we leverage Epic with our prior auth and our EMR, and we have it built in the auth requirements at the code level, at the payer level, and so we leverage the functionality of auto generating referrals, auto status assignment. So if something doesn't need auth, we don't have that go out through PAN. It's something we manage at the point of order or scheduling before that trigger to PriorAuthNow occurs. So that's how we manage it. And then obviously as payers change, we update the system. We drive that either the removal of prior auth or the now requirement of a prior auth. And that system just picks it up as we go out. And so it'll start hitting our auth work queues, and then it will go out through the transaction then.
Yeah, someone asked, does the PAN solution need to have the Epic EMR to work, or?
No, it does not. Again, in line with what I said earlier, we will meet our providers where they're at as well. And so that's from a technological capability as well as the individual EMRs that are out in the marketplace. We can integrate with all of them.
And lastly, what are the next service lines that PriorAuthNow and Cleveland Clinic are expanding to, and why those service lines?
So I can speak to it from Cleveland Clinic side. So we're looking to expand into the surgical space. And so where do we have opportunities to improve the surgical processing? So we're diving into that now and prioritizing based on opportunity as well as what efficiencies driven and how is that going to improve and support access, as well as ongoing conversations with our payers. And so we're engaged in active conversations about the solution, looking to leverage that. As Dan mentioned, it's not specific to Epic. And so they are customizable, and they do adapt to your process flow, and they didn't come in and say it's this way and that's it. They were able to bend around our processing, and that was key, right? Because we have a lot of downstream impacts for our prior auth processes and other areas that are involved, and we wanted to make sure those weren't impacted because there would have to be updates and changes there, which was great to see. And so I think it's just looking at where do we have more payer opportunity to leverage a solution like this to really drive those results.
Thanks, Dan. Thank you all again for joining. This was really exciting for industry to hear about how prior authorization burden can be automated and reduced in real time. I'll hand it over to Daphne for some closing remarks.
Thanks, Mariana. And just to echo that, thank you, Dan and Daniel, for sharing your insight and expertise with our audience today. I know we received quite a few questions from our audience that unfortunately we're not able to answer, but we'll make sure to follow up with you all on those questions. Just quickly here, all of what we discussed today, the operating rules, this pilot and measurement initiative, a lot of that is made possible through CORE participating organizations. So if you're interested in joining CORE, please reach out to our team. We also have an upcoming participant forum on November 3rd, where we'll be discussing our 2022 goals and priorities. Most importantly, thank you for our audience for joining us today. We'll make sure to follow up with you all. In the meantime, please reach out to us with any questions at core@caqh.org. Thanks, everyone.
Thank you.